I'm Paul, and I'm one of the allergy immunology consultants at St Mary's. I'm also based at Imperial College London. I spend most of my time, or I used to spend most of my time, giving people things they're allergic to and causing them to have anaphylaxis. And so I've sort of collected over the last sort of 5 or 6 years, hopefully a degree of data which I am really delighted to be able to share with you this morning, that hopefully might not immediately impact on how we manage anaphylaxis in hospitals, but at least help understand what's going on, so that when things go a little bit to pot, you've got a bit more of an idea of what to do. So please do type in your questions or comments as we go, and there are also some sort of straw polls that we'll do on the way to make sure that you're all awake still, hopefully. So at the moment in the literature, there are lots of different descriptions of anaphylaxis, and I'm going to call them descriptions rather than definitions because they are different things. But you'll notice that most of them imply a life-threatening or severe reaction. They're sort of quite scary. If you imagine that you're not medical and you're a parent of a child who's just had an allergic reaction, a non-anaphylactic reaction, and someone says your kid's at risk of anaphylaxis, and you go and sort of see what anaphylaxis is, you might get a little bit scared here. The other thing that often comes up as well is the idea that it's potentially fatal. Serious, potentially fatal systemic reactions. And it's all this sort of terminology that drives a lot of fear and anxiety on the parts of patients and working in paediatrics, families and carers of children. And they think their kid's going to be the next one to die. But there are a few issues with the current definitions that we currently have. So the first thing is anaphylaxis is often considered to be a systemic reaction. But what about if you have a child, like here we do on the right, who's having generalized skin reaction, but nothing else? Is that anaphylaxis or not? And that matters because we've had one death in the last 25 years due to egg allergy in the UK in a child. And that occurred because the child was having a systemic skin reaction, but not anaphylaxis. And because the skin reaction wasn't getting better, that child ended up being given an adrenaline overdose and died of the adrenaline overdose rather than the allergic reaction in the first place. So it's really important that we know the difference between just a systemic reaction and anaphylaxis. Other definitions talk about more than one organ being involved. So you might have skin and respiratory system or something like that. But what about a kid who's having an allergic reaction? As you can see, this kid here, he's got lip angioedema. He looks a little bit puffy in his face as well. He's got that sort of quiet look that often children have when they're having an allergic reaction. And he's also complaining of tummy ache. Is that anaphylaxis or not? Would we be reaching for adrenaline to treat that child? And increasingly, we're seeing severe reactions present essentially with respiratory symptoms in isolation only. Now, clearly that is potentially a life-threatening reaction, but it's only one organ as far as we can see. So is that anaphylaxis or not? And believe it or not, I've spoken to colleagues abroad who will say that they don't consider respiratory symptoms such as asthma symptoms in isolation after exposure to an allergen as being anaphylaxis, and therefore they'll treat for asthma, but they won't treat with adrenaline. So again, there are real consequences in terms of how we think things through here. And then we've got sort of the far extreme, which is sort of more respiratory or cardiovascular compromise. Cardiovascular compromise is fortunately relatively uncommon in children, and we'll come back to that in a second. And so it's really important to understand that anaphylaxis is just one end of a spectrum of severity. And then actually for anaphylaxis itself, there's a spectrum of mild anaphylaxis to very severe anaphylaxis, which potentially can cause death. Anaphylaxis isn't just one level of severity. There is this spectrum there. The key clinical features of anaphylaxis are summarized here on this slide. So it's a generalized allergic reaction, although it might not always appear generalized, with either respiratory or cardiovascular involvement. And as I mentioned, respiratory symptoms are far more common in children and also are far more likely to be the peri-arrest symptom when it's a reaction caused by food. It often involves many parts of the body, but not always. And usually it's rapid onset and rapid progression. So my first question to everyone is, a person with anaphylaxis, do they always show skin symptoms, true or false? So I'm going to hand over to Nicola, hopefully, and now click on your buttons as I am doing. And I've sort of given you a clue already. And also, for those people who remember how to answer MCQ questions in medical school exams, you can probably guess. Right, and then I think Nicola can share the results with us.
I can.
Do I need to stop sharing at my end? Or
Nope, here we go. There we go.
Ah, fantastic. All right. So for those people who don't remember how to do MCQ exams, if something always says always or never, it's almost always false, because nothing is always is that black and white in medicine. So it is indeed false. This report comes from the good old days where you could get something published in New England Journal of Medicine, a case series of only 6 kids. Nowadays, you have to work your butt off and have millions of hours of time to get a publication in that journal. But Hugh Sampson back then published a case series of 6 kids with fatal food anaphylaxis, only one of whom had skin symptoms. And one of the concerns that we had, that he mentions, is that people are so tuned, particularly in emergency, to seeing skin symptoms, that if you don't see skin symptoms, you often don't consider it to be possibly an allergic reaction. And therefore it might not get appropriate treatment, and therefore that might contribute to the poor outcome. And so there is increasing recognition, I'm delighted so many people spotted this, that you might not always have skin symptoms, but in the sort of heat of a moment in the acute A&E setting, it's really important just to think, actually, could something be anaphylaxis? And we'll have got a case scenario that we'll come to shortly. So the manifestations, actually, only 9 out of 10 people having anaphylaxis will show cutaneous symptoms. Around half will demonstrate respiratory symptoms. A third will have an element of cardiovascular compromise. And around a quarter to a third will have gut symptoms, as you can see in this slide here. And there is a sort of a change in what symptoms you see at different ages as people get older. So infants, for instance, having a bottle of milk and then reacting with anaphylaxis to that milk formula will often just appear pale and floppy and not do very much. As they go into sort of the preschool years, we'll start to see respiratory symptoms that mimic asthma come about. As they then start growing older and sort of teenage years, it's quite common for people to get an itchy mouth first, and throat tightness and itchy throat, which then leads on to respiratory symptoms. Whereas at least for food, cardiovascular compromise and even collapse are relatively rare. And so a lot of people often sort of look at the blood pressure and go, oh, he's not hypertensive, that's fine, no problem. But actually hypotension in a child or young adult having anaphylaxis is essentially a pre-terminal sign. And people sometimes get quite hung up on, measuring blood pressures. And actually you need to be able to evaluate the respiratory system predominantly through auscultation, just listen for the wheeze and change in expiratory phase and so on, and not worry about the cardiovascular stuff, because it's the respiratory stuff that tends to trigger arrest, and the cardiovascular arrest comes secondary to respiratory arrest in fatal reactions. The causes of anaphylaxis in childhood vary. So as you can see at the start in preschool, is it tends to be milk and egg. Around sort of 3, 4, 5 years of age, we start seeing an increase in tree nuts, peanuts and so on. As kids start running around outside a little bit, we then see sort of venom-induced anaphylaxis beginning to tick off a little bit. And then when you get to sort of teenagers age, we can see that actually milk and egg have generally disappeared as allergies and therefore aren't generally causing anaphylaxis in that age group. It tends to be peanut, tends to be less of tree nuts, because by that stage people know the foods they're allergic to, so they avoid them, whereas peanut is used quite widely and often appears as a contamination in lots of foods, so that continues to be a major cause. And then we also start to see drug-induced anaphylaxis as being more common in sort of teenagers, and that's then a pattern that takes off as people go into adulthood. Within the UK, it's really interesting to look at the causes of fatal reactions. And they do differ a little bit, but the really big surprise, I hope, that's standing out here are how many fatal reactions are caused by milk. Everyone's heard of peanut allergy and nut allergy now, but most people, particularly pediatricians, because we learn about cow's milk allergy in young babies, and it's only if you have exposure to more specialist centres that you realise that actually, while most people with milk allergy outgrow their allergy by sort of primary school age, and certainly usually by secondary school age, those that do not often have a more persistent phenotype that's associated with asthma and other allergies, allergic rhinitis, eczema as well. And they seem to be particularly at risk of severe reactions. And milk alone is the single most common cause of fatal reactions in the UK. And so while the perceived risk, of course, is about nuts and peanuts, actually the real danger is milk. You don't need much milk to get quite a heavy protein dose, and it's protein that causes a reaction. And milk is so ubiquitous in our diet that it can be very difficult to avoid. If you just think our habits of getting a coffee in the morning when shops are still open and so on, it's a significant risk factor. And suddenly all but 2 of the fatalities I've been involved with in the last couple of years have been due to milk. Hopefully everyone here recognises these plans. This is a snapshot of the BSACI allergy plans. If you type into Google or any other search engine allergy plan, you should hopefully get the BSACI plans as a first hit. And this is what every single family with a child with food allergies should have. You can download them and print them off for free. There are specific plans if someone has been prescribed an EpiPen or a Jex pen or something like that. And the idea is that it drives families to consider whether their child is having an ABC symptom, an airway, breathing or consciousness symptom. People are familiar with the ABC mnemonic. And if they are, to seek emergency help and use adrenaline if they have access to adrenaline. So I've talked about adrenaline quite a lot. And adrenaline, hopefully, is something we can all agree on. All the local, national and international guidelines say that adrenaline should be used first line for the treatment of anaphylaxis. And yet, typically, only 30 to 60% of patients with anaphylaxis coming to hospital, to A&E departments, whether it's in the UK or Europe or in America, are treated with adrenaline. And we're not quite sure why that number continues to be less than 100%. So I've got a couple of scenarios. Let's see what you guys all think. Let's try and understand why we might not use adrenaline. So got an 18-year-old female who's had a food challenge to peanut. This is one of the tests we use to diagnose allergy in a hospital. And because we try not to kill our patients, we give them very tiny doses first, and we wait 20 minutes, half an hour in between each dose. And then gradually they start having more and more doses, higher amounts of exposure, and we start to see symptoms. So the first couple of doses don't really do very much. This lady gets a little bit of itchy mouth and a bit of lip angioedema, which for the criteria we sometimes use in hospital isn't enough to stop the challenge. And then on the 4th dose, roughly about half a peanut, 140 milligrams of peanut protein, she complains of very severe abdominal pain. When I say very severe, we're talking about we would consider reaching for morphine. She's doubled over, very severe cramps, screaming out. Question for you all, is this anaphylaxis? And I'll hand over to Nicola. Okay. Right. How are we looking, Nicola? Okay, so that's interesting. So we've got 2/3 who say yes and 1/3 who say no. And it's interesting, as I'll show you now, because normally it's roughly the other way around when I'm giving this talk in the UK. So these are the current clinical criteria for diagnosing anaphylaxis that are agreed upon throughout the world, except in the UK and Australia. And essentially what we're talking about is these three groups: either respiratory or cardiovascular compromise, plus exposure with skin involvement. So that's number one. Number three is a drop in blood pressure alone after exposure to the allergen. And then we've got this middle group. So within this middle group, we say, well, skin or respiratory compromise, or C, reduced blood pressure, or this wishy-washy thing here, persistent gut symptoms. And one of the problems is that there's no real definition for what persistent means. And there's not a real consensus over what we mean by gut symptoms. So for example, if someone is having nausea, but quite mild nausea for 20 minutes, does that tick the box for persistent gut symptoms? And if therefore they were having it with skin, would we call that anaphylaxis and therefore they should have adrenaline? Or does it have to be pain? And if it's pain, when does pain become persistent? 10 minutes, 20 minutes, half an hour, 2 hours? And what about if it's mild pain that comes and goes, that's intermittent? When would that then trigger us to consider it to be a symptom of anaphylaxis rather than an allergic reaction? And at least within the UK and Australia, when it's a reaction to food, we don't consider gut symptoms to be concerning because the food is sitting in the stomach. So we consider it more to be more like a local reaction. That's different from if you get stung by a bee on your arm and then you start vomiting up or having abdominal symptoms. You got stung here, but you're getting symptoms in your gut. That's more concerning. But at least for food allergy, in general, in the UK and Australia and other parts of Europe, we don't consider skin and gut to be anaphylaxis. And this causes a problem then if you then look at what you're meant to be doing in managing anaphylaxis, looking at data from America and from other countries where they do include gut symptoms, but they don't always specify, well, what sort of gut symptoms matter or not. Let's have another sort of case here. So 12-year-old male, peanut desensitization. So this is a new treatment that we're doing in certain specialist centers. And 30 minutes after having peanut, he suddenly becomes wheezy with a tight chest and has no other reason for why he might be wheezy. He's not been recently unwell, no upper respiratory tract infection symptoms. He hasn't suddenly been exercising or anything like that. Is this anaphylaxis? Over to you, Nicola, and the rest of you to fill in the poll. Okay, how are we going? Let's see. Okay, so most of you say yes, it is, 84%. A few of you say no. And I would say it is, but if you look at the definition for anaphylaxis that we're all meant to be using, we've got someone with just respiratory compromise. So we haven't got someone with skin and respiratory compromise. So he doesn't tick the box for number one. He hasn't ticked the box for number three because he's not got reduced blood pressure. And he doesn't tick the box for number two because all he has is respiratory compromise. So according to the international definition for anaphylaxis that we currently use, that case would not be anaphylaxis. Whereas actually, I think all of us would certainly be right to treat it as anaphylaxis. And in the UK, at least, and Australia, we would say this absolutely is anaphylaxis, 100%. And we shouldn't be reaching for asthma medicines for this scenario. We should be reaching straight for adrenaline and intramuscular adrenaline. So these are some of the problems when you begin to overthink what's anaphylaxis or not. But of course, when you're writing protocols and training, you need something in writing to tell people what to do. And so, as by means of an update, the WAO and my sort of conflict of interest is I'm now chair of the Anaphylaxis Committee for the World Allergy Organization. We are now proposing these new definitions for anaphylaxis. And you can see that on the screen at the moment. And this should have been signed off already, but because of coronavirus, we haven't achieved the global consensus that all the national allergy societies are happy with this. But what we're saying is that we're sort of combining numbers, numbers 1 and 2 in the old definition into one single thing where you'll have skin involvement plus at least one of the following. And we are trying to be a bit more specific over gut symptoms. So we're saying we're talking about severe crampy pain, and we're talking about someone is themselves mute. So I don't know if you can also just all check. Thank you, perfect. And then we are also now saying that acute isolated hypotension or wheezing or laryngeal involvement alone is sufficient to say this is anaphylaxis, even in the absence of typical skin symptoms, because as I told you already, lots of fatal reactions don't present with skin symptoms. And what we're trying to do is just highlight the fact that you can have anaphylaxis without skin involvement there. So watch this space. These guidelines are likely to start coming out over the next year or two as we return to normal. And we're currently rewriting the UK Resuscitation Council guidelines, which will also hopefully incorporate this new definition. Okay, controversy 3. So we're used to seeing headlines such as this of people who've had very severe reactions. But actually, the majority of anaphylaxis is not always severe. And it's really important to understand this so that we can understand how to look after patients well in hospital. And this is some work that colleagues of mine, so some who may well be online, and Bob Boyle, Robert as well, who may also be online, did and published about 7 years ago now, actually. And this shows the likelihood of bad things happening to you if you are a child with food allergy. And so, for example, 1 in 10 people are very likely to attend A&E because they've hurt themselves. About 1 in 250 are likely to attend A&E because they've been involved in a motor vehicle accident. Being murdered, we're talking about 1 in, where are we? So in America, about 1 in 50,000. In Europe is about 1 in 500,000. That's called gun control. And then dying because of lightning strike, about 1 in 10 million here. And you can see that actually the likelihood of having a fatal reaction due to food is less than the likelihood of dying because you've been in a car accident. And so if you were a pure statistician looking at this, one would say that you're more likely to die coming to see me in hospital for your annual clinic appointment than you are because of your food allergy. And that's actually what statistics show. But the problem we have is that we can't, if I were to tell families that in clinic, they would report me, if I'm lucky, to the local patient liaison service. And if I'm unlucky, they'll fill in a form to the GMC. And the problem that we have is that when anaphylaxis affects someone we care about, so our child or ourselves, we understand risk very differently. And I say this as someone whose son has had anaphylaxis. That if we say your chance of something bad happening is 1 in a million, as doctors and scientists will go, well, that's not very much. But when it's personal risk, we understand 1 in a million as being, yes, that one is going to be me or my child or something like that. But where this data can be useful is in terms of counselling patients. We can say, look, it's really risky. We take risks every single day of our lives. We drive, but we don't just drive. We drive and we get in a car that's been safety rated. We put our seatbelts on. The car has airbags. We follow the highway code. We stop at traffic lights so that we don't just drive and hit other people crossing the road and so on. There's safety netting involved. And the same way we take safety netting so that everyday risks become acceptable, how do we safety net for food allergy? And so part of that is about rescue medication, as we'll talk about. So provision of adrenaline pens and medication treatment plans. But part of that is also families and children knowing how to manage reactions and increasing awareness and making sure schools understand things and act appropriately in terms of managing the risk of anaphylaxis too. There is data that clearly shows most anaphylaxis isn't life-threatening. So within the UK, back in 2011, a group of allergy clinics did a survey of teenagers, 869 teenagers, to say what's happened in the last year. Have you had an allergic reaction in the last year by accident? And 245 of them said yes, and it was anaphylaxis. And 80% or so of them who had anaphylaxis, they did not use their adrenaline pens. They didn't die, nothing bad happened to them, and around a year later, they came back to tell us in clinic, I had anaphylaxis, and look, here I am now. So clearly, 80% at least of teenagers having anaphylaxis, if they do nothing, they will get better. In much the same way that if you cut yourself, you don't need to go to hospital for sutures. Usually you will clot. You might need to put a steri strip on if it's a bad deep cut, but the body will try to heal itself. And in the same sort of way, when someone has anaphylaxis, the body tries to compensate. And so what we see are the people who have either presented because of another concern, anxiety or something, and actually they are now post-reaction, or more concerningly, they are presenting to us because they're still having anaphylaxis symptoms and there's been a failure of compensation, in which case we need to handle them very differently because there's already been a problem. They haven't responded like normal people in much the same sort of way that people with haemophilia, with clotting disorders, if they have significant bleeds, we have to manage them very differently because they are at risk of very severe consequences if we don't get on top of their bleeding. The same may well be true for severe anaphylaxis. So anaphylaxis isn't uncommon, but death from anaphylaxis is very rare. And if someone is still coming to hospital and they still have anaphylaxis symptoms, they are at higher risk of death. And actually around 1 to 2% of people who come to hospital in the UK and Australia and America still with anaphylaxis symptoms will end up dead. So even though the likelihood of dying from anaphylaxis is low, if you're still having active symptoms when you get to hospital, you're instantly in a higher category. And that's why these patients having anaphylaxis symptoms still need to be triaged and rapidly escalated to majors or resus or so on. If they've had anaphylaxis and their pen has worked, there's not such an urgency. But if they're still wheezing, that is a medical emergency. But the problem we have is that out in the community, people think all anaphylaxis is the same, all anaphylaxis might be fatal, and that might be because food allergy is increasingly common and people's perception of food allergy is that it's increasingly common. Nowadays, every single thing you pick up will say may contain peanut or something like that. You go into restaurants, and because of the recent deaths we've had, every restaurant now says, tell us if you've got allergies. So people's perception is that actually food allergy is far more common and severe food allergy is far more common than it actually is. And I've told you this bit already, that people perceive risk very differently when it affects you, and in particular when it affects your own child. You know, we've done a lot of studies in adults where we've got the parent with food allergy and the child also has food allergy. And when we just talk to them in conversations, say, you know, how do you treat your own or manage your own risk differently from your kids? The adult parents always tell us that they're far more protective over their children and risks they'll let their children take than they are themselves. It's just what we do as parents. Okay, here's another case for you. 8-year-old boy, he's having a food challenge to what we call baked egg. So this is like a cake that contains egg in hospital. And 30 minutes after that reaction, has mild generalized urticaria, nausea, and a little bit of wheeze, and says my chest is a bit tight. For those of you who work in more an acute setting, just think about if this was happening to someone on the ward or an emergency. You know, you can see they've got urticaria, feeling a bit sick, and a very soft expiratory wheeze, but the kid is otherwise completely fine. So very mild asthma symptoms. Is this anaphylaxis? Yes or no? Okay, over to Nicola. Okay, good. So 8 out of 10 of you have said yes, and 1 in 5 of you have said no. This is anaphylaxis by any definition. By the UK definition, they're wheezing. By the international definition, they have skin plus respiratory, so that's two systems involved. That is anaphylaxis. But next question, and please be honest, what's the treatment you are initially going to reach for? Think about it. I'm sure many of you have seen this sort of scenario in emergency or something like that. What do we do? Nicola, can we have the next poll? I'll give you a couple seconds longer. Please do be honest here, because it is revealing. Okay, let's see what you say. So, 1/4 are reaching for adrenaline, 1/3 for salbutamol via spacer, which reflects the change in using salbutamol via MDI and spacer now rather than just going straight for nebulized. And thank you for being honest, 1/3 of you are going just for antihistamine. And that is typical. And to show it's not just you, but it's me too, these are some reports, 5 reports from the major allergy centres dotted around the world in terms of how we manage anaphylaxis at Food Challenge. And you can see there are lots of numbers. I've stuck myself there in the middle. And you can see that even in allergy specialist settings, the vast majority of children having anaphylaxis in hospital don't get treated with adrenaline, which everyone agrees is the first line treatment for anaphylaxis. And so were these people to die, we would be struck off because we have ignored every single guideline that's ever been written for the management of anaphylaxis. And I don't know what we're scared of, because actually it works really quickly and it works really well. It doesn't hurt, as I hope to show you very shortly. And it massively improves people's quality of life and reduces anxiety level when they use adrenaline in hospital. What we did here was when people had anaphylaxis in our research studies, if they had anaphylaxis, we got the kids themselves to self-inject with that auto-injector device. And essentially, we saw a massive improvement in levels of anxiety and what we call self-efficacy, confidence in treating your allergy, when they used their adrenaline and they realized it doesn't hurt very much and it works immediately. And the problem that we have as healthcare workers is that if we avoid injection with adrenaline, we're actually reinforcing the myth that you shouldn't use adrenaline to treat anaphylaxis. And so we're doing the opposite by what we should be doing, very much so. We're doing these patients and ourselves a disservice rather than taking the opportunity to use adrenaline when they're still having anaphylaxis symptoms as an educational initiative. And it's even more important that we use adrenaline, as I said, if they've come to emergency and they've already used medication and they're still having anaphylaxis symptoms. So this young man is Max. I've got permission to show you his video. He's having anaphylaxis in hospital with us.
It's okay?
Yes, go.
It's a real pen.
Push it in. Hold it, click.
1 and 2 and 3.
And you'll see he didn't flinch at all.
6 and 7 and 8 and 9 and get it out.
So if that's using an EpiPen in reality, what are we scared of? It doesn't really hurt. It might hurt a little bit, but actually it always hurts less than people think. And by doing that, it's an incredibly strong educational experience so that people aren't scared to use their pens in the community. Right. Does adrenaline always work? So as you can probably guess, it's not really ethical to take people, whether adults or kids, give them anaphylaxis, and then say, we're going to treat half of you with adrenaline and half of you we're not going to treat with adrenaline. We're just going to leave you and see what happens. And so the data for you managing anaphylaxis with anything is quite poor. And essentially, it's epidemiological data, some case series, fatality registers, and predominantly expert opinion. But as I've shown you, everyone says use adrenaline, and adrenaline certainly can work. I'm hoping you can see my pointer here. I don't know if, Sharanya, I can see you on my screen. Nod if you can see the pointer. Is that coming through? Brilliant. Okay. All right, my pointer's now just disappeared. Come back, pointer. Here we go. So what we've got here is these vertical lines are the blood pressure of someone about to have anaphylaxis, and the continuous line is heart rate. And he's about to get stung. Actually, this is a bite from a jack jumper ant. This is a patient in Australia. And in Tasmania, about 10% of the population are allergic to this particular venom from this really nasty ant. And so there's a massive public desensitization program in order to treat these people and avoid anaphylaxis, which is often very severe. So S stands for sting. This is where this lucky person is about to get bitten by the ant. And you can see the drop in blood pressure, really very precipitous, that happens. And then this person is given intramuscular adrenaline with fluids, IV fluids, and you can see dramatically how things get better quite quickly within minutes. So adrenaline certainly can work. But then we have cases such as this, where, again, this is a similar sort of setup of someone having an insect sting. This is to a patient having a wasp sting, and this is someone happening in an anaesthetic room. This is from a research study. And they're a bit anxious, their blood pressure's up at the very start, as you can see. They get stung, and within minutes, there's a massive drop in blood pressure, both systolic and diastolic. And likewise, an initial drop in heart rate, which is always quite concerning, that then increases to quite significant tachycardia. Each black square here is roughly a 5 to 10 times overdose of the amount of adrenaline in an EpiPen given intravenously by an anaesthetist. And it has diddly squat impact on blood pressure until this person gets started at 40 minutes here on a noradrenaline infusion. And this is what happens in really severe anaphylaxis. You'll know, I'm sure, the tragic story of Natasha and Laperouse, the girl who had the baguette in Pret in Heathrow a couple of years ago, and then died on board a BA flight to Nice. And they used EpiPen, and this is probably why it didn't work, because if someone is having this level of a severe reaction, 1 or 2 little dots, squirts of adrenaline from an EpiPen is not going to help you. You need lots of adrenaline, and you need IV fluids to support that. And so these people really need to get to hospital and be managed by people who are used to giving lots of adrenaline and IV fluids in that sort of scenario. And that's why in the UK, 1/3 of the fatalities we've had in the last 20 years use their adrenaline pen early and correctly, and yet they still die. Because sometimes 1 or 2 shots is just not enough. It buys you minutes, and we need to use those minutes for the paramedic crews to get to you, to keep giving you more treatment, and to get you to hospital urgently and acutely. Now, what happens during these very severe reactions? Well, we've got a clue. There's an amazing guy called Malcolm Fisher who worked at North Shore Hospital. It's quite a large hospital just in the north of Sydney. And he was an anaesthetist who noticed that a lot of his patients kept on having anaphylaxis when he anesthetized them, and decided to start watching and seeing exactly what happens. And out of 227 people having perioperative anaphylaxis, he collected details on about 200 who really had severe hypotension during their episodes. And he reported these guys had arrhythmia, there was clear myocardial dysfunction when we were looking at the ECG and where they were doing echoes on these patients. And by doing serial hemoglobin measurements on the blood gas machine in 22 of these patients, he reported that in severe anaphylaxis, you lost around 1/3 of your blood volume within minutes. Okay, so if you've got, as an adult, fully grown adult, 4 to 5 litres of volume in your blood, you lose around 1.5 litres within minutes of having severe anaphylaxis. And that probably explains why there are now reports of people who are having anaphylaxis, who are self-compensating, but when they get moved, either from a lying position to standing up or from sitting to standing, such as when the paramedics arrive and say, okay, let's walk you to the ambulance, or so on, that triggers the fatal event, because simply they just can't compensate. They don't have sufficient circulatory volume. And this is what's known in layman's terms as empty heart syndrome. There's a massive fall in circulating volume. The heart simply doesn't have enough venous return to pump blood around the body. There's no perfusion of the important organs of the lungs, of the brain, and so you arrest. And actually what we've shown is that that happens in normal people as well. So these are patients, adult patients, having allergic reactions with us in hospital. And what we've found is that when they have allergic reactions, even if they're not having anaphylaxis, there is a drop in stroke volume. There's a drop in venous return. It's subtle, it's only about 10%, but there's a drop. But then these people compensate. None of them died on us, and none of them had really severe anaphylaxis, and they compensate by increasing their heart rate. So even though there's less blood to pump around, because the heart is pumping faster, they're maintaining cardiac output. That's what happened in normal allergic reactions and anaphylaxis. In severe anaphylaxis, you don't compensate. There's a failure of compensation, and therefore these people effectively are at far greater risk of dying. Where's this 1.5 litres of fluid going? So, you know, if you think to puff up with 1.5 litres, when we've looked after people where they have peripheral angioedema, or this term third spacing, which is a term that I hate, you know, you have vascular leak, you don't have third spacing. Where does all this fluid going? Well, they don't puff up like the Michelin Man, so it's probably not going into the skin. And I came across this case report of a prisoner who was having an anaphylaxis reaction to a drug. And he didn't present with rash, and got transferred to hospital with hypertension. And then around an hour or two later, started getting urticaria. And that's when the penny dropped. They thought, oh, that's interesting. Maybe it's an allergic reaction. Gave him adrenaline. And the hypotension responded, but he continued to have really severe abdominal pain. So they stuck him in a CT scanner. And what they found was significant bowel wall edema, which is what you can see with the red arrows, fluid in the bowel lumen, which are the right arrows, and the yellow arrow here is pointing to the ascending vena cava. And that's much smaller than it would normally be. So there's reduced venous return back to the heart. And so what we think is happening is that this fluid goes into the gut, and that's why we get gut symptoms of anaphylaxis. And this is some data that we're hoping to publish very soon. It's under review at the moment, where we've shown here the drop that people have in stroke volume when they are having anaphylaxis with us. And then in half of them, we gave them IV fluids. And in the other half, we didn't. And you can see that, unsurprisingly, when we give people IV fluids, and we talk about IV fluids, a large volume given over 20 minutes, so around 0.5 litre to 1 litre over a 20-minute push, very quickly, one restores that stroke volume, which is exactly what you'd expect. The heart rate normalizes. And importantly, the symptoms, the abdominal symptoms, get better quicker than if they weren't treated with IV fluids. And this was a paired study. These were patients who on one occasion had reactions that we didn't treat with IV fluids, and on another occasion had IV fluids as part of their treatment. And so there really is a role to manage reactions differently. We're not saying treat everyone with anaphylaxis with IV fluids, but what we're saying is that if you have a patient and initial treatment doesn't work, give them IV fluids, because that's going to help with circulation of the adrenaline. It's going to help restore the cardiovascular problems that they have during anaphylaxis, the drop in stroke volume, and you're more likely to avoid really bad outcomes, which are likely to happen in 1 in 100 cases if that's the scenario you're seeing in hospital still. It's not just about giving the adrenaline, it's about recognizing the symptoms, getting the patients to a place of safety where they can have IV fluids and lots of adrenaline if they're going to need it, and giving fluids to support the adrenaline. Now, just some other sort of controversies. We've got about, I want to talk for another sort of 5 or 10 minutes, so I'll zoom through this bit because I do want to make sure there's a bit of time for discussion. People often go, how many devices should I be prescribing when I see a patient in clinic? So over to you, Nicola. How many devices do people prescribe at the moment? Do you prescribe none in general, one pen, or more than one pen? Where's my... Okay, Nicola, share us what people think. Fine, okay. So most people prescribe some pens. So my mouse keeps disappearing. There are lots of different risk factors that people put forward for severe reactions, and you'll see them up here. Age, certain triggers, I've told you about cow's milk already, asthma. We think asthma is a risk factor, but actually we're not sure about that, and I haven't got time to talk about that too much because asthma is so common. Roughly 1 in 2 people, at least children with food allergy, will have a diagnosis of asthma as well. So it's not very helpful in terms of predicting risk because the majority of people won't actually end up having severe reactions with food allergy. People who've had anaphylaxis before, obviously at risk of more anaphylaxis again. People who have what we call a biphasic reaction, where they have initial symptoms that get better and then they come back. People in unfamiliar surroundings, so if you're away on holiday or things like that, or not getting adrenaline early. But I've already told you, adrenaline alone doesn't prevent mortality. And so looking at the guidelines, these are what the various sort of learned societies have come up with. So if you've had anaphylaxis before, yes, you should probably have an adrenaline pen. But then we've got these sort of patient-specific factors for which there's not much evidence. And essentially, what we're looking at is it possible you might have anaphylaxis? If so, then we should probably be offering families an adrenaline pen. If they don't want it, that's fine, but it needs to be a shared decision with the families. And the reason that we need to be doing that is because we don't understand what are the drivers of severe reactions. And one of the models that we use at the moment now is this sort of what we call the Swiss cheese model, the idea that there are lots of things that can go wrong. And just like when airplanes crash, it's not one thing going wrong. We see that the holes in the cheese line up. It's 2 or 3 things that you just need one thing to work and it doesn't end up with an air crash. But if you get 2 or 3 things that all line up, the holes line up, that increases the risk of severe reaction. And we see this all the time when we end up being witnesses at coronal inquests. It's never just one single thing that results in a severe reaction. And the problem is we can't identify people who are at risk of really severe reactions. And so the bottom line is at the moment, we have to treat everyone as if they are at risk of severe anaphylaxis. The current advice on the MHRA is that people need to have 2 pens with them at all times. And that isn't 1 pen in school for kids and 1 pen at home. That's 2 pens in schools and 2 pens for the child. Some of you may be aware that we're trying to get schools to have generic adrenaline pens so that kids don't need to take their own adrenaline pens to school anymore, but we're not quite there yet. And so that's why at the moment, essentially we're forced by the regulators to prescribe 2 auto-injectors. Now, we might not want to, and indeed the local British guidelines say children don't necessarily need to have 2 pens at home and 2 pens in school. It could be 1 pen at school and 1 pen at home. But my advice to you all is that having taken advice from medical legal organisations and the coroners, while you would not get sent to jail if you looked after someone who died and you'd only prescribed them 1 pen, you would be severely reprimanded and censored because the guidance from the regulators and the Department of Health is quite clear. And so at the moment, rightly or wrongly, we are sort of forced to prescribe 2 pens. Question for people: how often do you need more than 1 dose of adrenaline to fix an anaphylaxis reaction? Over to you, Nicola. Okay, let's have a quick look at the poll. Right, so half of you say 1 to 5 and then a bit of a spattering. elsewhere. So we've just done a meta-analysis to look at, in the literature, how often does someone with anaphylaxis need a second dose, and that second dose is given by a healthcare professional. So presumably it's not given because the family are just anxious, but a doctor or nurse or paramedic has listened and assessed the patient and said, no, you're still having anaphylaxis. And it's about just over 10%. So 1 in 10 anaphylaxis reactions don't respond to just one dose. And on the basis of the cost of adrenaline pens in the UK being around £18, it's actually cost effective in the UK for people to be prescribed 2 pens at the moment. The other thing that goes wrong is that sometimes people don't use their pens properly. And so in a study that, again, Robert Bowel and Sunta up in Oxford ran, called the Mama Study, they observed that roughly only in 2 out of 5 cases are the pens used correctly. And the things that can go wrong is that people don't take caps off, they don't hold the pen on for sufficient time, they apply the wrong ends, and if you apply the wrong ends, you can inject your finger. And so it's really important that maybe we need a second pen, because sometimes the first pen is used wrongly. But what's astounding is that it's not just patients who use pens wrongly. And this is a study that was done in Melbourne. This is the Royal Children's Hospital in Melbourne, where some of us have worked at. It's essentially the Great Ormond Street in one of the Great Ormond Streets in Australia. And out of 100 senior registrars and consultants, including emergency doctors, who were given a trainer pen, told to read the pen, and then demonstrate how to use it, only 2 of them could demonstrate it correctly. Fine, it was a little bit sort of semantics, but actually there were major issues with some of them. In 16 out of 100 cases, they held it upside down, and had it been a real pen, the doctor who is responsible for training these families on how to use a pen would have self-injected their thumb. And in 1/3 of cases, no epinephrine would have been administered at all. So we've got to know how to use these sodding pens, because if we don't, there's no way our families and our patients can know. There's a lot of discussion at the moment over what dose we should be using. And essentially, just to keep it really simple, if they're small kids, so not yet in school, 150, which is a dose in a junior pen. If it's a bigger kid, 300, and if it's a teenager or adult, 500. And we use 1 in 1,000 adrenaline, IM. The reason for that is that if you were giving the IM dose using 1 in 10,000, instead of 0.5 mils, you'll be giving 5 mils. And I'd like to challenge anyone to give themselves a 5 mil intramuscular injection and see how much it bloody hurts. That's the only reason for the stronger form of adrenaline that we use in anaphylaxis. It's the same dose as we use for cardiac arrest, it's just 10 times concentration, so we can use 1/10 of the volume. The pens that are available in the UK at the moment come in different lengths, needle lengths, different strengths. I'm not going to get too much into the needle length issue because it's quite complicated. We're now getting data to show that in lean people, we want an intramuscular injection, but in fat people, and lots of us are fat, around 1/3 of children now have too much subcutaneous tissue for an EpiPen to give them an intramuscular injection, but it doesn't seem to matter. So here's a study where they gave people EpiPen and measured how much adrenaline is in the blood. And you can see here the dotted line is people where it would have given a subcutaneous injection. And you can see that the adrenaline absorption curve is very similar to the people where they got an intramuscular injection. And we're currently trying to understand why that is at the moment. So I personally don't get too hung up on needle length. It's more important that the person is getting the right dose. The first rule of prescribing is prescribe the right dose. So we should be prescribing 300s or preferably 500s if we had a device currently licensed to adults, because that is a dose for them if they're having anaphylaxis. I really just very quickly want to show you this graph though, because I think this does impact now on how we might manage anaphylaxis in hospital. What we've got here on the left are the changes in heart rate when people are using an adrenaline pen, and the change in stroke volume on the right. when people, again, use an adrenaline pen. These are teenagers using an EpiPen or an Emerade pen, but not in the context of them having an allergic reaction. This is from a pharmacological study that we did in these kids. And you can see that what we've got, the dotted line is the adrenaline in the blood that we measured. And then the solid line is what the change in heart rate or stroke volume is. And you'll see that for Emerade, we get quite a quick increase in adrenaline that then lasts quite a while. Whereas for EpiPen, you get a quick peak, and then it diminishes quite quickly, particularly compared to the Emerade 300. But the peak that we get with the EpiPen 300 is much more than the peak that we get with the Emerade 300. And what we can see is that when you get a very quick adrenaline injection, your heart rate goes up, but actually the stroke volume goes down. Whereas when you get a more gentle adrenaline injection, both the heart rate and the stroke volume goes up. And this is a well-known effect of adrenaline, that when you inject adrenaline quickly, slow injections of low doses have a chronotropic and an inotropic effect. Heart rate goes up and the heart pumps harder with stroke volume. Whereas a very quick injection causes a heart rate to go up, but not the stroke volume. It has a negative inotropic effect. That's one of the reasons that we use noradrenaline in intensive care rather than adrenaline, because of this feature of adrenaline infusions. And so the EpiPen actually has a black box warning on it to say that adrenaline can cause this negative inotropic effect when it's used too quickly. It just hasn't been overly reported so far. And these are the first data to show that it might be a problem even with the adrenaline in an EpiPen. And it's probably because it's a very rapid injection with a cartridge rather than the other devices, which are a slow injection with a syringe mechanism. And the reason I'm showing you this data now is not to say don't prescribe your patient's EpiPen, because quite clearly EpiPen works, and actually we don't have Emerade on the market at the moment, they've been withdrawn. But if someone comes to hospital and they've already used their EpiPen and they're still having symptoms, please don't use EpiPen for the next dose. Please get a needle and syringe and give a needle syringe injection of adrenaline, because then A, you can give them the right dose for their age. So if they're an older kid or adult, it will be a 500 dose. And B, you're going to avoid this negative inotropic effect, just in case if that's the reason why they're still having anaphylaxis. So please don't use autoinjectors for a second dose if you are able to use a needle and syringe. And all trolleys should have a 1,000 ampule and needle syringes on them. Okay, in the interests of time, I'm going to stop after these slides here, which is just talking about the use of steroids. Very quickly, back to the poll. Who gives steroids in anaphylaxis? Fill in your poll now, or as soon as Nicola, who I've probably tricked because she thought she had a few more minutes. There you go. So who gives steroids in anaphylaxis? Okay, over to you, Nicola. Let's see what people say. So a bit of a mix. Still, some people just give it with mantra, some people give it sometimes, and so on. Let me show you these data. So we've had a recent meta-analysis, well, recent, it was about 4 or 5 years ago now, looking at all the published data, total of 4,000 patients with almost 200 of biphasic reactions. And what they found was that actually, if you gave steroids, so the top graph here, if you gave your patient steroids, they were more likely to have a biphasic reaction, not less likely. Now, actually, the reason for that is probably because of confounding, that the people who are more likely to get steroids are the people who are more likely to having severe reactions. And if you have a severe initial reaction, you're more likely to have a biphasic reaction. But certainly steroids are not protective. And so if someone is having anaphylaxis, we should not automatically have a knee-jerk reaction to prescribe them hydrocortisone or prednisolone. And there are now data to show that even 1 or 2 days of steroids can impact on the hypothalamic pituitary axis. Rather, what we should be doing is that if someone has had anaphylaxis, but perhaps our asthma's been poorly controlled and we're worried about the asthma, maybe one might want to prescribe a short dose of oral steroids to help with asthma control. I can probably see Andy squirming in his chair. Well, I can't because he's not on camera. That's a whole different debate, and I think that's probably another teaching session alone. But don't prescribe steroids routinely for anaphylaxis because there's no data that it helps, and there are some data to suggest it might be counterproductive. Fine, so I'm going to stop there, other to show you this, which is the Research Council current guideline for anaphylaxis, which I hate because it gives the impression that you only need to give one shot of adrenaline and then you just do all this other nonsense, including giving people Piriton. And actually, hopefully, the new revised algorithm, which will be published, we hope, later this year, is more likely to really emphasize the role of repeat IM adrenaline, using intravenous fluids for people who are refractory to initial adrenaline, and thinking early about low-dose adrenaline infusions or getting someone with expertise in giving low-dose adrenaline infusions in order to avoid the consequences of too much IM adrenaline when someone really needs quite intensive management to try and reduce the fatality rate that we have. Thank you for listening.
Paul, thank you very much indeed. We're actually on the button at 9:30. Maybe if there are some quick questions, if you want to ask Paul a question, hit the chat button and type in your question. So you've obviously been so comprehensive. That maybe there aren't any questions. Paul, thank you very much indeed for a fantastic talk, which I'm sure all of us have learnt from. I certainly have. We had more than 60 on the call at the best, and this seems to be working very well. Next week's call is going to be on severe and complicated pneumonia that Ross Langley is going to give from the Brompton. I'd just like to thank Paul very much for a really great talk. Thank Nicola for organising the hardware and making it go so smoothly, and hopefully see everybody next week. Many thanks indeed.
Thanks, Owen. Thanks, Nicola and Andy. Everyone have a good day and keep well.
Very good. Thank you.
Take care.
Thank you.
Thank you, Paul. Bye.
Thank you, Paul.
Thanks, Paul.